Good morning, ladies and gentlemen. Thank you so much for joining us for this very important topic. I will be talking about hazards of hospitalization for older adults. And I'm going to really focus a lot of my attention on patients with dementia because everything that I talk about for older adults is exaggerated among those who have dementia. As Jody mentioned, I'm with the Department of Geriatric Medicine at the John A. Burns School of Medicine. I have to give a lot of kudos to our leadership at UH who've recognized the importance of geriatrics. We are one of only 7 departments of geriatric medicine in the country. So the John A. Burns School of Medicine has really taken the leadership in this area. I'm also the academic medical director of the Queen's University Medical Group, a geriatrics program. These are the sponsors. It's Halikuike, Catholic Charities, the Administration for Community Living, and our own Department of Geriatric Medicine and our Geriatric Education Center. Our learning objectives today, I'd like you to know more about why older patients are more prone to complications in the hospital, and particularly those who have dementia. There are ways we can prevent these complications. Bed rest, which people talk about a lot, about, somebody needs to rest because of whatever reason, is actually very bad for our bodies. Older people are also more susceptible to adverse drug events. And I'll end with talking about some new models of care for better outcomes in the hospital. So I'll just start with the hospitalization rates in older people. If you look at this graph here, the dark blue is people who are 65 and older, and the lighter blue is those under 65. And you can see this is the percentage of the population that are over 65. We're currently hovering around 16% of the population. But yet, when we look at hospital admissions, the rate is much higher. It's about a third. And when we look at costs of hospital care, hospital spending, it's almost half of the costs. So clearly, anytime you visit the hospital, when you look around you, most of the patients there are going to be in the older age group. Now, going to the hospital can be life-saving. There are times when it's absolutely necessary. But hospitalizations are also landmark events in the lives of older people and frequently mark that transition from health to frailty. This is a quote from a paper in the Journal of the American Geriatric Society from 2000 by one of my mentors, Dr. David Rubin, who's the head of geriatrics at UCLA. And I absolutely agree with him that while hospitalization is often necessary and very helpful, it can really mark a transition in people's lives. So once people are hospitalized, older people are very likely to lose independence or to be placed in an institution. So when there have been studies done and people over the age of 70 years, 1/3 will leave the hospital with a new disability. Recovery of these disabilities from hospitalizations can take up to 2 years. Now, the most of the benefit will happen in that first 6 months, but for many older people, the recovery can be very slow. And for some of them, they're never going to recover from that disability. The risk factors for functional decline, of course, the first one is older age. So somebody who's 65 will not respond the same as somebody who's 95. Obviously, the older the person is, the harder it is to recover and come back from functional decline. Somebody who has a previous disability and problems with mobility is also at higher risk. People who have cognitive impairment, whether it's dementia or other types of cognitive impairment, or even depression, have a harder time bouncing back as well. Poor nutrition is a risk factor. And the longer someone stays in the hospital, the higher these risks become. So why are older people at risk? Well, what happens is in a younger person, they have a lot of what we call reserve. This is true in every organ system. in the heart, in the kidneys, in the liver, in the lungs, all of that. As people get older, there's less and less reserve. When you have acute illness or stress, this kind of exaggerates this problem. So you can see here, this younger person, even when they have acute illness and stress, it's still within their reserve capacity. But in somebody who's older, it's not. Now it leads to frailty. And in somebody who's in extreme old age, that's basically called, because the reserve is so low now, when they fall down, they won't get up again. This younger person could bounce right back. The older person may not. There's also an increase in disease burden in an older person. These are some of the common things that older people will have. The top two, actually, congestive heart failure and pneumonia, are two of the most common reasons for older persons to be hospitalized. In fact, when they've done studies, they've looked at those two, and they're usually number one or two. One or the other is number one or two. So those two are extremely common. In older people, urinary and other infections can also be an issue. Heart rhythm problems, heart attacks, emphysema, diabetes, stroke, and unfortunately, adverse drug reactions can be a very common reason for why people need to be in the hospital. So you first have decreased reserve, and you have an increased disease burden. Both of these cause age-related morbidity and disability. This is again exaggerated among people who have dementia. Now, when you add the hospital-associated stress and insults, that can often lead to disaster. In older people with dementia in particular, I think twice, 3 times, 4 times, 5 times, 10 times before deciding to put them in the hospital, because the hospital is such a difficult place for patients with dementia. Now, there are many risk factors. So getting the patient from the hospital to home, in some ways, is like walking a tightrope. And there are many risks that are happening in between. There are problems with sleep, hearing, vision, delirium, depression, falls, pain, catheter use, nutrition, infections, medications, bed sores, restraints. A lot of these things can cause the patient to fall off and not be able to return home. And that's usually what people want, right? They go into the hospital not wanting to go into a nursing home or into a care home. They want to come home. But all of these factors are in the way and sometimes can cause them to trip off that tightrope and not be able to get back home. So on admission, they have to have a very good assessment of their baseline function, not while they're sick, but when they were well, before they got sick to come into the hospital. How good was their mobility? How good were their activities of daily living? Were they able to bathe by themselves? Could they dress themselves? What types of things could they do or not do? What's their social situation? Is the patient living alone? If they are living alone, who helps them? Or are they living with family or other people? The baseline cognitive status is really, really important. We know from studies nationally, internationally, and even locally that dementia is often unrecognized and undiagnosed. It is a very common concern. One of the studies that was done right here in Hawaii found that 2/3 of dementia was missed in the community setting. When we looked at mild dementia, 90% of mild dementia was missed in the community setting. So often people can hide this and they don't, even their loved ones may not realize what's going on. Even their doctors may not realize what's going on unless you look for it. Home medications. And were they taking these medications? This is a really common issue. A patient has hypertension or high blood pressure, and they're put on a medication in the clinic. They're not taking the medication, but the doctor doesn't know that. So they add a second medication. Now they're supposed to be taking two medications for high blood pressure. They're not taking either one. They come into the hospital and it's on their list of medications. So the people there assume, of course, that they are taking those medications. They put them on those medications, suddenly the blood pressure drops out because it was not, they weren't taking it in the first place. So it's really important for the doctors in the hospital to know were they actually taking their home medications or not. Does the patient have advanced directives? Do they have a pulse? I'll be discussing this in more detail a little bit later. Now, many of you who've been in the hospital or have had a family member in the hospital know, often your primary care doctor won't actually be seeing the patient in the hospital. Nowadays, we have the hospitalists. All they do is hospital medicine. So they're there, they take shifts, and they're really, really good. So that is one of the benefits of hospitalists, is they get very good at hospital medicine because that's literally all they do. The problem is they don't know the patient. If it's your mom or dad in the hospital, they don't know your mom or dad. It's their primary doctor who knows them. So that's why communication between the different specialists and the different doctors is so very important. Now, one of the things we look at for all patients, but even more importantly for patients with dementia, is goals of care. Patient autonomy is important. They need to be able to make their own decisions about their care. In patients with dementia, they may not have that ability anymore, but hopefully you as their loved one have talked to them while they were able to make those decisions so that you can then convey your loved one's wishes. Goals can really vary. I've had some patients who say, prolong my life at all costs. I want to be on machines if I have to be. More commonly though, majority of my older patients have told me, I don't want to have life support. If I have an illness that I'm not likely to recover from, I want comfort. Please focus on keeping me comfortable. My main goals are to stay independent as long as I can, to have good quality of life as long as I can, not necessarily to live longer. So it's really important that the physicians know what the patient's goals of care are, so we can follow the patient's wishes. We always ask, do you want to be resuscitated if you have a cardiac, that's heart, or respiratory, that's lung problem? What that means is, if your heart stops, do you want CPR? Do you want us to give electric shocks to your heart to get it started again? If you stop breathing, do you want to be put on a breathing machine or a ventilator? What about ICU care? Is that okay or not? Many invasive and painful procedures are done in the ICU. I've had some patients where they've said, it's fine to put me in the hospital if you need to give me comfort, but I don't want to go to the ICU. I don't want tubes coming out of everywhere. I want to be kept comfortable. It's really important to know, just because we can do something does not mean we should do it. I, for example, have an advance directive that very clearly states that that quality of life and independence is more important to me than staying alive longer. A lot of patients will have advanced healthcare directives. It's very important that they share these with their family and with the physician and with the hospital. There's no point in having it locked up in your safety deposit box, because if you're in the hospital or if you're very ill, nobody can get to that box. So it's more important that you have it shared with everyone. These advanced healthcare directives kind of tell your providers what you want for your care. It's very important that you do that. But it's impossible to predict every possible outcome. So it's also important to have what we call a durable power of attorney for healthcare, where you're naming someone. Usually people will choose a family member or a very close friend who will make decisions on your behalf. if you're unable to make those decisions for yourself. There's also a document called the POST. POST stands for Provider Orders for Life-Sustaining Treatment. It's in this lime green color, the form. They've purposely designed it like that so that it's very easy for paramedics or people who come into your home to find. The POST is an order that the paramedics will actually follow. So if you have a very serious or terminal illness, and if you want to be sure that you're not put on a breathing machine, for example, you're not given CPR if your heart stops, you need to have this POST signed by your provider, by your physician or a nurse practitioner. And then you should make sure that it's displayed very prominently in your home. Most people put it either on the refrigerator or the back of the front door or somewhere where paramedics can easily find it. And again, it's in this lime green color so that it pops out to the view very easily. If you don't have this, then the paramedics, when they show up at your house, even if somebody will tell them, mom or dad didn't want CPR, they will go ahead and do the CPR. So this is the only way that you can get them to not do it, is to have this prominently displayed in your home. Make sure your doctor and your hospital have copies of all of these documents. I want to talk a little bit about bed rest because people talk about this saying, oh, you know, they're having pain, they need to lie down in bed, or they're really tired, they need to have bed rest. Well, bed rest can be helpful, but I want you to know the consequences that happen with bed rest. Muscle strength decreases 5% per day of bed rest. So you can imagine if somebody is in bed for 4 or 5 days, they've lost about a quarter of their muscle strength. Bone loss from 10 days of bed rest can take 4 months to restore. You can get contractures. This is where the joints kind of won't straighten out completely. So can you imagine if your knees are always slightly bent and won't completely straighten out, you can imagine your walking won't be very good, your balance won't be very good. You can develop blood clots in the legs that can be very dangerous. Weakness, falls, fractures, all of these are consequences. Pressure sores. It's really important to get people out of bed as quickly as it is safe. That's why you will often see people who've had surgery, even serious surgery, often start their physical therapy either the day of surgery or the very next day after surgery to get people out of bed, to avoid all of these negative consequences of bed rest. Now, mobility impairment, we talked about this, is very common in the hospital. These are some of the associated problems: deconditioning, falls and injuries, physical restraints. Physical restraints where people are tied down in bed can be terrible. It can really cause agitation. Environmental hazards. There are a lot of cords that people are attached to in the hospital. You can imagine if you're trying to walk with all of those things, you can easily trip over some of them. If you can't get out of bed, urinary incontinence can become a problem. Or pressure ulcers, which are bed sores, can become a huge problem. So some of the solutions to these, one is early mobilization. Get people out of bed quickly. Have a call bell so people can call and have help to get out of bed. Sitting in a chair for meals is important. You can imagine if you're lying down and trying to eat, you're going to have a lot of problems with that. Assistance with toileting. One-to-one sitters can be very, very helpful in the hospital, particularly for patients who have dementia, who get very disoriented. If family can do this, sometimes I've seen family, if they have large enough families, they take shifts and somebody is always with the patient to keep them oriented and to make sure that if they're trying to get out of bed, somebody's there to help them. Physical therapy and occupational therapy, they are super important for older people, and to do those as early as possible. Assistive devices can be helpful. I give this I put this picture in because I actually had that example with one of my own patients. She was having some mobility issues, and so I had her using a cane. And every time she'd see me, she would raise her arm, her cane, and be waving it to me. And I'd be telling her, use your cane. And she'd say, I am using my cane. And I was trying to explain to her, that's not what I mean by using your cane. I mean, use it properly, to help your walking. Removing restraints is really important. People put on restraints thinking that that's going to prevent falls. Actually, studies have shown restraints don't prevent falls and can cause even more serious falls. So keeping restraints off, but using other means of keeping people safe are very important. And then removing catheters and IVs as quickly as possible so that the person can get up and move is also very important. Pressure ulcers are also called bed sores. So basically what happens with bed sores is the weight of the body is over here. This is the skin and all the layers of fat and muscle. And then this is the pressure from the mattress coming up. So you can imagine if somebody is not moving around very much, that can cause a lot of problems with the skin. There are some common areas that we see bed sores. This is basically all the places where bone is close to the surface and is touching the bed. So the back of the head, or even the back of the ears, people don't think about that, but that can actually be an area that develops sores. The shoulder or the elbow. The lower back and buttocks are the most common area actually. But even the sides, the hip bone, if somebody is lying on their side a lot, that can be an area. The inner knees or the heels. So all of these are the common areas to develop bed sores. With bed sores can come infections, pain, and functional decline. It's caused by pressure, but it's worse if there's friction and worse if there's moisture. That is why the buttocks are such a vulnerable area, because often patients who have incontinence are in diapers. Yes, in the hospital, they will try and change the diaper often. But again, especially if the patient has dementia and is unable to call out for help or unable to express that they have a wet diaper, sometimes it can be missed. And that moisture can certainly worsen the risk of having these bed sores. So what are the solutions? Nurses do a good job doing a daily skin exam. They should be examining particularly all of these high-risk areas. Turning somebody frequently, at least every 2 hours, and not keeping people on these bony prominences as much as possible. So we usually don't like people to lie at a 90-degree angle on that hip bone. We prefer that they lie at a 30-degree angle to avoid that pressure. Checking those risk areas, particularly the back, the buttocks, the heels, and all the other bony areas. Good nutrition is important. You can imagine if there's malnutrition, this fat layer and skin are much thinner and it's much easier to break. Having a good mattress. Time toileting to keep dry. If people are able to go to the bathroom, again, a dementia patient may not recognize that they need to go to the bathroom. So instead of asking them to take them to the bathroom every 2 hours or every 3 hours or whatever interval is good for that person, to keep them as dry as possible. The key for bed sores is really prevention. Once they start, then treatment can take a very long time. So prevention is really, really important. Sleep and sensory impairments. The hospital is not a good place to get rest. If any of you have been in the hospital, you will know this. Bright lights, lots of noise, beepers going off, and other devices making a lot of noise all over the place. It may not be you, it may be the room next to you or your neighbor next to you. There's a lot of activity that goes on in the hospital, even at night. It's very, very hard actually to get a good night's sleep in the hospital. Hearing and vision problems are common on older people. And again, that can exaggerate some of those risks from being in the hospital. Delirium, I'll be talking about a little bit later, but that's an acute confusional state seen in the hospital, and anxiety just from being in the hospital. Functional decline, all of these things are problems. Imagine you're waking up in a strange place. Your glasses are somewhere else, you don't have them. Maybe your hearing aids are not on you. And these blurry strangers are poking and prodding at you. Now imagine you also have Alzheimer's disease and this is happening. How disorienting is that? It can be very scary for older people. So some of the solutions are make sure your environment is as clear as possible, reduce noise if possible, have bright lights so people can see. Again, the sitter, having a one-to-one sitter, encouraging family to stay nights. Nights can often be very difficult for patients, especially with dementia. Frequent reorientation, make sure you have a calendar on the wall. Usually it's better to have those tear-off calendars, so it's just one date that's showing, but then make sure it's the correct date that's showing. Have a clock that's very easy for the person to see and read. Keep the patient active during the day. Can you imagine if you're sleeping in bed all day, of course you're going to be up all night. Kaiser has developed this wonderful activity program specifically for patients with dementia in their hospital, where if they're not doing procedures or not busy doing other things, and if they're well enough, they actually go to an activity room. So they're up and doing things during the day so that then they can sleep at night. Hearing, make sure that people have their hearing aids on. Speak slowly and clearly, check for earwax and clean that out. Sometimes that can make a huge difference. And make sure that the person has their glasses nearby. The bladder and bowels can be a problem area too. Urinary incontinence is very common in the hospital. It's associated with severity of illness. Of course, the more sick somebody is, the less likely they can keep their urine continent. Also, access to the bathroom. If somebody is tied down or if they have multiple wires connected to them, you can imagine by the time they get all those wires straightened out and get to the bathroom, they might have been incontinent, or waiting for the nurse to respond can be an issue as well. Unfortunately, catheters are often used in the hospital. I like to get those out as quickly as possible because they can cause complications of their own. Having a bladder catheter is wonderful in the sense where you don't need to go to the bathroom, but we know that that increases the risk of infection of the bladder as well. So get them out quickly. Constipation. Again, people who are in bed all the time, maybe they're not drinking enough liquids, maybe their diet isn't very good. Constipation can cause poor appetite, abdominal pain, can contribute to delirium, all of those problems. Again, you're seeing the same theme, right? Get out of bed quickly, get the catheter out, put them on a timed toileting regimen. Maybe a bedside commode might be helpful if it's hard to get to the bathroom. Monitor bowel movements. If somebody is constipated, make sure that they get some help for their bowels. Certain medications can cause either incontinence or constipation or even diarrhea. Maybe avoid those medications and give laxatives if necessary. Malnutrition. Now, many older people have poor nutrition even before they come into the hospital. And of course, in the hospital, this will only worsen. Dehydration is also very common. And both of these, malnutrition and dehydration, will increase the risk of hospital complications. So what does this mean? We want to make sure that people can chew properly. Do they have their dentures in? Are they able to swallow? Are they able to swallow safely? If not, maybe a speech therapist needs to come and do a swallowing evaluation. Is the diet too restrictive? Somebody who's losing weight in old age, I find that to be more dangerous than having a high cholesterol, for example. So often, if I'm seeing older patients who are losing weight and are very malnourished, it's so hard to get out of that cycle I want to make sure I liberalize their diet and let them eat pretty much anything they want because the weight loss is something I don't want to see. Are they given enough time to eat? Are they being given help to being fed? Again, if you have family who can help with this, that is so wonderful because they will provide help in the hospital, of course. They will have nurses' aides or nurses helping, but they have a lot of patients to see to. So if you can provide this, it is so wonderful. Is it a medication side effect that's making them not want to eat? And then do they need dietary supplements? Medications are a huge issue. Medications can be life-saving and can also cause a lot of problems. So we are always looking for adverse drug events. I told you before, that's one of the most common reasons that people have complications in hospitals is because of adverse drug events. Delirium or an acute confusional state from medications, falls, functional decline. All of these effects are more common and more severe in older people, and again, exaggerated among people who have dementia. You can get into this vicious cycle of adding more and more and more medications. Solutions, monitoring drug levels, avoiding certain high-risk medications that we know are not very good for older people, simplifying drug regimens, and trying to prevent these adverse drug events. Dementia, these patients are at highest risk for poor outcomes due to hospitalizations. So it's very important to consider both risks and benefits before making that decision to hospitalize. Review the goals of care. Again, is it important to keep the person alive longer or to have comfort care? Depression is very common in the hospital as well. Almost 40% of hospitalized elders have some signs of depression. So again, we need to very early evaluate for delirium, have preventive strategies for delirium like frequent reorientation, monitor medications. If somebody is depressed, consider antidepressants. Again, no matter what the reason is for the older person being in the hospital, chances are high they may need rehabilitation, at least physical therapy, if nothing else, just to strengthen them up again. Imagine if they're feeling depressed, they're not going to cooperate with the physical therapy. So sometimes people may need antidepressants to help. Family, again, can be the biggest help. Frequent reorientation, reassurance, help with feeding, safety, all of those things family can provide for their loved ones. I've talked a lot about delirium, so I want to talk about it a little bit more in detail here. Delirium is different from dementia or Alzheimer's disease. It looks similar, but it's actually different. It's an acute confusional state that fluctuates. Now, a patient with Alzheimer's disease also can be quite confused, but Alzheimer's doesn't come on over days. It comes on over years. Delirium will come on over hours to days, and it'll fluctuate a lot. These patients have poor attention and may have an altered consciousness. What do I mean by that? They may be extremely lethargic and hard to wake up at all, or they may be hyper alert and extremely agitated, and they can bounce back and forth between those two states. It's very common, unfortunately. It's seen in over 30% to up to 50% of patients over the age of 70 in the hospital. Many factors contribute. The illness itself, the medications, being in a new environment, all of those can contribute to having delirium. It is associated with longer stay in the hospital, higher mortality, and functional decline and disability. So delirium is not, yes, it is a temporary condition in the sense that it will resolve, but it can have a lot of very serious consequences, including even death. People at risk should be identified and treated very early, and even some prevention measures should be put into place in the hospital. Infections. This has been even more noticeable to us in the last 2 years, right? With this crazy pandemic. Good hand washing is very important for prevention of all infections. And please don't visit the hospital if you're sick. Even if it's just a minor cold, please don't visit, because that's the last thing somebody in the hospital needs, is to also get an acute infection. So it's really, really important to try and avoid these as much as possible. I'll end my talk with some new models of care that people have come up with nationally. One of them is the ACE unit. ACE stands for Acute Care for Elders. So some hospitals have done this, where they've created an ACE unit, which is specifically a ward just for older people. They provide an environment that promotes early mobility, so getting people out of bed, so they have a lot of therapy assistance in those wards, and orientation, so that people are constantly reminded about the day and the time and that kind of thing. These wards have a lot of different professions working together. It's not just doctors. It includes nurses, social workers, pharmacists looking at medications, physical therapists, occupational therapists, dietitians, very much a team-based, so that the patient gets every aspect of their care looked at every single day to prevent some of those complications that I talked about earlier. Early social work intervention to plan for discharge. Maybe the goal is to send the patient home, but maybe they're not safe to go home yet. Maybe they need to go for rehab into a nursing home for 2 to 3 weeks to build up their strength to go home after that. All of these are done on a daily basis in these ACE units. And they found some very good outcomes. They found better function for those patients, better patient satisfaction, and even reduced costs. So even though you're providing more resources, it's still reducing the cost of care, which is what we want, right? We want higher quality care at lower cost. And that's what these ACE units have been found to do. Unfortunately, none of the hospitals in Hawaii have an ACE unit yet. There are other models of care that are new. One is the HELP program. HELP stands for Hospital Elder Life Program. And it's very specifically a delirium prevention program by managing 6 factors. Cognitive impairment. So again, to know what the patient has at baseline, and then to prevent delirium. So whether they have dementia at baseline or not, and then to prevent new onset of delirium in the hospital. Sleep deprivation, to make sure that that sleep-wake cycle is kept. Make sure that they're mobilized early, kept walking and out of bed as much as possible. Looking at vision and hearing impairment and addressing both of those. And then looking at dehydration and making sure that that's corrected as well. Another model of care is a surgical co-management program. For example, for hip fractures. We know most people who have hip fractures are going to be of older age and will have all of these risk factors that I talked about. So they have, of course, the hip fractures taken care of by the orthopedic surgeon who does the surgery, but they have a team that does surgical co-management. So they have a medical team of either geriatricians or hospitalists who are trained in some of these preventive factors. Another model of care is the hospital and home program, where instead of coming into the hospital for certain conditions, the hospital comes out to you in your own home. Sometimes even 2 to 3 times a day, nurses might come to your house, maybe to give you IV antibiotics or something like that. This program is actually available here in Hawaii, but only at the VA. So it's only available to the veterans here in Hawaii. It's not available at any of the other hospitals. But this is a growing program, again, that has shown wonderful outcomes, including better patient safety, better patient satisfaction, and lowering costs of care. So when we have a patient who's being discharged from the hospital, if the patient is being discharged home, always we have to think about this. Does the patient need a caregiver, or are they safe being alone? Do they need equipment or some kind of home safety evaluation? Home safety evaluations are super important and very, very helpful. This is where either a physical or occupational therapist will go to the patient's home and will look for hazards. Is there poor lighting? Do they need rails, like handrails somewhere? Do they need, especially in the bathroom, are there loose rugs, or are there other hazards, loose wires that people can trip over? And they can make recommendations to fix those problems. If not to home, are they being discharged to rehab or nursing home? If so, for how long? What is the ultimate goal? Is the ultimate goal to get home or for long-term care? So good communication between the hospital, the nursing home, or the hospital and the primary care doctor are really, really important so that nothing is missed between these transitions of care. And then the patient and their family need to understand medications. They've done some studies to show if the pharmacist can meet with the patient before discharge, patient and family, to explain medications, then it's so much better for the patient and the complication rates are much lower. Family needs to understand what the care needs are going to be. The family needs to know the prognosis. If the patient has a terminal illness, the family needs to understand that and needs to have some realistic expectations about what will happen once the patient goes home. Rehab, again, the rehab therapists are our best friends. Occupational therapy, physical therapy, speech therapy. So the physical therapists will look at mobility, strength, range of movement. Occupational therapists look more at self-care. Is the patient able to dress themselves, feed themselves, get out of bed, things like that, bathe, and they will help try and maximize that to the best of their ability. Speech therapy helps with communication or with swallowing problems. There is Rehab Hospital of the Pacific. It's on Kokini Street, right across from Kokini Hospital. And some patients will go there, but a lot of my older patients can't go to Rehab Hospital. And the reason for that is, in order to qualify for that insurance benefit, you need to be able to have at least 3 hours of rehab a day. And often a frail older person just doesn't have enough stamina. They can do the rehab, they just cannot do 3 hours a day of rehab. So many of them will end up, instead of Rehab Hospital, going to a skilled nursing facility for rehab. And that can be very helpful as well. Some can go home and either get outpatient rehab or home rehab, where the physical therapist, occupational therapists come home to you. And good rehab is really critical for recovery. So in summary then, hospitalization can be a crossroads for older people, especially those with dementia. We always have to weigh the risks and benefits before deciding whether to put an older person in the hospital. But complications can be prevented with good care. And we always need to know what our patients' preferences are and try and follow them to the best of our ability. And lastly, rehab is very important for recovering that functional independence. These are just some diagrams. These are little obstacle courses. And unfortunately, often this is what an older person feels like when they're in the hospital. They have many little pitfalls that they have to try and avoid to get out at the other end. So just to end with a little humor, my doctor told me to avoid any unnecessary stress, so I didn't open his bill. I thought that was cute. And then this one, now I know why they call it ICU. Aren't those gowns crazy, those tie in the back gowns? I hate those. I will end with that and see if any of you have any questions. I'm going to stop my screen share. Any questions?
Yes, thank you. That was really funny, those cartoons. Thank you so much. All of you, this poll came up. While we address the questions, please respond to the post-test, which is the same questions that you got in the beginning. So please, everyone, answer the poll. Yes, Dr. Masaki, that was just wonderful. I'm going to go off camera and read you the questions.
Thank you.
All right. First question, is a hospital bed mattress considered a good mattress?
Yes, it is. So many years ago, I think it's been like over 15, 20 years ago, all of the hospitals changed all of their mattresses to be low pressure. I remember when I was training as a fellow, that was over 30 years ago. I don't want to give my age. But at that time, for my older patients, I used to actually order a special mattress for them. And then after a while, they called me and they told me, you know, we replaced all our mattresses in the hospital. They're all low pressure. You don't need to order this anymore. Now, given that, there are some people who are either very high risk for bed sores or already have bed sores where certain mattresses can be ordered. Those are they're like air layered mattresses. Those are very special mattresses. They actually have to rent those. They're very expensive. So you have to meet the qualifications. But for certain people, they will order those. But for the majority of patients who are just in the hospital normally, there are low pressure mattresses are the norm now in all our hospitals.
Thank you. I have my father and stepmom who are fiercely independent and live in their own 3-bedroom house. Dad still works full-time, mostly from home, and regained his revoked license a few months ago and still drives on his own to downtown a few times a month, ! Dad leaves his wife at home for 4 to 6 hours at a time, and this is the main concern for her safety of being home alone. Stepmom recovered from falling out of bed after 1 month rehab earlier this year. She has early signs of dementia, but is always calm and social. Both are feeble, but can walk on their own without walkers. I want to somehow transition stepmom to a Monday, Wednesday, Friday senior daycare to give her a more social environment and not allow her to take long 3-hour day naps because she's alone and bored. This way, Dad can have a break from being named caregiver and can leave his home for work-related duties on those Monday, Wednesday, Friday days. Do you have a checklist and baby steps recommendations to make this transition from home to daycare work? I don't want to try and fail! !
Yeah, you know, so often patients themselves are very resistant to daycare. And actually, once they go there and once they, develop the relationships with the people there and actually have fun, most people who go to daycare really enjoy it. It can become a very positive experience. So I would say it definitely sounds like in this situation with your mom, stepmom and dad, that this would be a very positive thing. I think choose the daycare wisely, go around and look at daycare programs, talk to the staff, find one where you feel that your family would fit in well, and then let them know and give it a try. You won't know until you've actually tried, but don't give up too quickly because often people who are initially resistant will really enjoy that.
Thank you. And there is a comment on that from someone. We try not to call it daycare. We refer to it as a senior program to social club. I know adult day health or yes.
Yes, I completely agree. The way you package it and the way you talk about it can change the person's viewpoint completely.
Thank you.
Very good point.
Since hospitalization places people with dementia at further risk for decline, I can see why hospitals are wanting to discharge the patient as soon as possible. The problems we are seeing is that there is no strong support system or family who are willing to provide care or supervision to the family member. Additionally, there are a lack of care home, foster home providers who are willing to accept the client. The patient unfortunately ends up staying longer at the hospital because there's no safe place for the patient to go.
I agree. And that is something we as a community need to address. So often these patients will be sent to a nursing home temporarily and to a rehab facility. Now, the problem with patients with dementia is that some of them will be able to cooperate with therapy and some will not. You know, if the dementia is pretty advanced, then they just won't be able to make progress with therapy. And often, once that therapy ends, then the dilemma begins, right? Because then you have to make that decision. Okay, long term now, it's not a short term issue. Now it's a long term issue. Where's this patient going to go? And in order to go home, you're right, to be able to go home safely, they need that caregiving and that support. And if they don't have it, then often they will end up in either a nursing home or in a care home. The care home system in Hawaii is actually pretty good. It's quite amazing. It's so much better than it is in most other places. I think we're very lucky to have some really wonderful care homes here.
There's a comment about that. Nursing homes are all facing staffing challenges in this tight labor market. That was just a comment.
Oh, that is you have said it. Right now, every nursing home I know that we are connected with, they're struggling to keep staff. And the pandemic has really hurt because many nurses' aides in particular, nursing has, I think they said, I saw this number, 25% of the nursing workforce has left nursing in the last year. This is nationally. I don't know what the numbers are in Hawaii, but I know a lot of people have left. Nurses' aides is even more challenging. You know, nursing aides, I gotta say, the certified nurses' aides, that's one of the lowest paid jobs, and I think it's one of the hardest jobs. I know I couldn't even do it. It requires a lot of physical strength and a lot of emotional patience to be able to do that job. And a lot of them have left that field because I think partly because of the COVID surges that they've been through, and then the hotels are paying more. And so many of them are just saying, forget it. They have to work 2 jobs, 16 hours a day to make it. It's really, something needs to change in our system.
Thank you. Could you address hospice as it relates to your topic, or do you have a separate presentation? Thank you. I just want to mention that we do have a whole series on hospice on our website, and I'll let you answer that, Doctor, but in our dementia trainings page, which you have the link to that I sent to everyone, there are about 34 webinars that are recorded there, and there's about 3 or 4 of them that specifically address hospice and dementia. Go ahead, Dr. Masaki.
Thank you so much, Jody. Yes, that is an excellent question. So palliative medicine is actually a whole different field of medicine from geriatrics. And it's a specialty. People can actually do a fellowship in palliative medicine. We don't have one yet here in Hawaii, but the Division of Palliative Medicine at the John A. Burns School of Medicine is actually under the Department of Geriatrics. Geriatrics overlaps so much with palliative care. So our fellows, they're training to become specialists in geriatrics, get a lot of palliative training, including hospice. So palliative medicine includes all types of comfort care, not just hospice refers to the last 6 months of life. So to be eligible for hospice, the doctor has to give you a prognosis of 6 months or less to live. This is much easier to do for cancer, certain diagnoses like cancer, and much harder to do for other diagnoses like congestive heart failure, emphysema, chronic kidney disease, and dementia. Dementia is probably the hardest. I've had patients with dementia where they have certain hospice criteria. If you have dementia and you have all of these factors, then you meet criteria for hospice, saying you have a prognosis of less than 6 months to live. But I can tell you, I have been wrong so many times. So they've met all of those criteria, I've enrolled them in hospice. 6 months have passed, a year has passed, 2 years have passed, and the patient is still alive. I think actually that's one of the tragedies of Alzheimer's disease. I have seen patients in end stage Alzheimer's where, they're curled up in a fetal position in bed, they're nonverbal, they're barely eating. It's hard to believe. And I've seen those patients live for years like that. So hospice is definitely an option with dementia, but I just wanted to let you know that it's harder to predict prognosis in dementia than it is in some of the other chronic diseases.
Thank you. Can you please speak to the option of using an external condom catheter as a viable alternative to an indwelling catheter?
Yeah, those are not very good either. In general, I don't recommend catheters at all. So the condom catheters can cause sores around that area in the skin, and they can leak, and they can cause infections of their own. So no, in general, I don't recommend catheters. If somebody is completely incontinent, which does happen at end-stage dementia, then usually we put those patients in diapers, but then try as much as we can, if they are able to, do time toileting, if possible. But if, at some stage, they may not be able to even do that. And then I recommend the use of diapers and really good skin care, really good changing of the diapers, rather than using any type of catheters.
Thank you. Is there any services that provide IV administering in a home?
I'm sorry, giving IV medications?
IV medication, I guess, or IV administering it.
Yeah,
yes.
IV medications. Yeah. So there's a yes and a no to that. It depends. Some of the home health agencies can provide IV services to a certain extent. But again, if it's a lot, then they won't be able to. The hospital and home program does provide IV medications even multiple times a day. But as I said, in Hawaii, that program is only available for VA patients right now.
A comment, thank you for the lecture. Appreciate the comprehensiveness of the topic. Yes,
Thank
Dr.
you.
Masaki, you rule on that for sure.
Thank you.
Okay, do you have a reference for the ACE unit, and do you see that model being successful here in Hawaii? What does the reimbursement look like?
Yeah, so the ACE unit there's no special reimbursement. It's not like a special benefit like hospice. So Medicare has actually created a hospice benefit where if you go off regular Medicare and you go into hospice, you can disenroll from that, by the way. So if 6 months have passed or even more have passed and you decide you don't want hospice care anymore, you can get your regular Medicare benefits back. So the ACE unit is not like that. There's no special benefit for it for insurance. It's just that the hospitals around the country have created that type of program where they've got specific staffing ratios, which are higher than normal wards. They have the correct expertise for physicians and for rehab and for other specialties going in there, and they have specific protocols that they follow. I don't know whether Hawaii will ever have one or not. I know that some of the hospitals have talked about it. I know we've talked about it at Queens, but there are many initiatives going forward. So I can't predict when exactly an ACE unit will actually be available.
Thank you. Medical staff differ in their understanding of advanced dementia in general, and your loved one in particular. I have found it very useful to have express discussion and even send email or note to clinic or hospital about my wife's dementia, personal quirks, etc., like new doctors, not gerontology team. Any thoughts of suggestions on how to do this without stepping on toes? So far, no problem.
Yeah, no, I think the more you speak up, again, it sounds like you're doing, if you've had no problem so far, it sounds like you're doing it just right. I would say keep doing that. You are your loved one's best advocate. You know them best. The physician won't know them. No matter how good the physician is, you're living with this person. You've lived with them for many years. You know them. Make sure you express that. In the hospital, if the patient is in the hospital, there will be shifts of people coming. So just talking to people won't be enough. put written instructions up there. You know, if you know that the person likes something or doesn't like something, make sure you talk to people, put it up on the little board that they have over the bed if you want, those kinds of instructions so that they will follow them. It'll be best for your loved one.
Thank you. My mother-in-law has dementia and lives in a nursing home, and father-in-law lives in assisted living in the same place. She needs fed meals, and dad is not allowed to be in the nursing home dining room, and they don't feed her. When they come to our house every weekend, I feed mom, and she eats really well. What can we do to help her get fed at the nursing home?
Is it because of COVID that they're not allowing them to feed? Because that's very unusual. Is it because of the COVID problems?
Maybe that person, anonymous, could you type in that answer or chat it into us? We'll,
Because prior to COVID, there was never a problem. Family were actually welcomed to the nursing homes to go and visit and to try, and especially at meal times, because that was wonderful for the staff to have, you know, instead of having to spend the time feeding somebody, they could spend their time on other patients who didn't have that luxury of family coming to feed them. During COVID, especially for that first year, everybody shut down all visitation. And you know, I understand why it was done, and you know, we really wanted to contain the surges, but it did have a very negative effect on the patients for many reasons. Part of it was just loneliness, depression. Part of it was the feeding, because now they weren't being fed as well because the family couldn't come in. Most recently, though, Medicare has ruled that you cannot stop family from visiting at nursing homes. So in fact, now it's gone the other extreme. We've had nursing homes where we have an active outbreak going on and we cannot stop visitors, even though we think we should stop visitors just for a couple of weeks. They won't let us stop them. So I would check again. The rules are changing all the time. And right now, as far as I know, they have to let visitors into the nursing home.
The person did respond, Dr. Masaki, yes, it is because of COVID.
Yeah. I would check again, because right now, as I said, we're having active outbreaks because of this Omicron variant at nursing homes. And we're telling the nursing homes, maybe we could slow down on visitation just for a few weeks. And they're saying Medicare won't allow us to do that. So now it's gone the other extreme for now you can't stop anybody from coming in, even if they're not vaccinated. You can't check any of that stuff. It's kind of crazy. So please check again, because now they might be able to go in.
Thank you. My mom called her daycare going to school since she had weekends and holidays off.
Yeah.
She was in her 90s and I got a kick out of that.
That is very cool. That is really cool. I actually, it was kind of sad, but also kind of sweet. There was a retired doctor in one of the daycares, and he had Alzheimer's, unfortunately. And he used to sit there and basically examine patients. It was funny, you know, they wouldn't let him write prescriptions because they knew he shouldn't. But the family actually, because he didn't want to go to daycare, but they told him, hey, you can go and have a clinic. And so he used to actually go and he'd listen to people's lungs and heart. And, you know, his Alzheimer's was too far gone, so he couldn't really do much more than that. But it was like his clinic for him, you know, and it kept him entertained, and the other patients were fine with him, and he wasn't doing any harm. And so great. Yeah, if they want to go to school, great.
Thank you. Thank you very much for the lecture. What would you recommend for someone who is fiercely independent all of their life? They're starting to show signs of dementia, but still drive and want to maintain that independence and get very angry when you try to bring up change.
Yeah, I would work with your doctor on that. So I do want to tell you a little bit about the driving laws in Hawaii. So each state has different laws. I do know in California, it's actually mandatory reporting. So if the patient has not just dementia, but any other condition where the doctor is worried about them driving, it's mandatory reporting to the DMV. Here in Hawaii, it's not. And in fact, patient confidentiality is considered more important than reporting to the DMV. So what I've had patients that have dementia that I feel should not drive. And I've talked to families and I've told them, I can't report, but you can. So if you wanted to report, you could to the DMV to get their license taken away. Even more important than that, though, some people with dementia will drive even without a license. So to make sure you disable the car or something like that. One option is to get a driving evaluation. Rehab Hospital actually has a driving clinic where they'll do an evaluation, like a road safety evaluation. They have a simulator, and I think they also do some road safety. So you could ask for that. Just know, though, that's only good for this point in time, and dementia usually will progress. So you can't keep doing driving evaluations every few months. It's also expensive and it's not covered by insurance. It's a difficult conversation to have, but at the very least, I would talk to the doctor about it. Maybe sometimes the doctor's recommendation can help with that patient stopping driving. Not always, but sometimes. Nowadays, at least with things like Uber and Lyft, other options are available to people which weren't available in the past. So again, something to consider. And then having family and friends be available all the time so that they can go where they want to go without constantly having to worry about it can help as well.
Here's a good question. Are there enough geriatric physicians in Hawaii for the growing aging population? Also, what about nationally?
Okay, so thank you for that wonderful question. It's one of my pet peeves, actually. No, nationally, geriatrics is considered a federally designated critical shortage specialty. Currently, I think the need is for 30,000 geriatricians in the US. I think the actual number is less than 7,000. And the number of older people is going up each year, and the number of geriatricians is going down each year. Half of the fellowship positions in the country go unfilled for geriatrics. It is a low glamour specialty and it is a low pay specialty. So the reason we do it is because we love it. We love our older patients. That's what gives us joy in life. You know, we're not doing this for the pay, that's for sure. But I think that's why I like all my colleagues so much. They're all wonderful people with great hearts. In the state of Hawaii, we're a little bit better off than the national average. And the reason is because we have our fellowship here. We have one of the larger fellowship programs in the country. We've had over 200 graduates in our history, and almost half of them have stayed in Hawaii or in the Pacific region. So Hawaii does better than the rest of the country. Some of our graduates, when they graduate, they leave and they go, they're the first geriatrician in a medical school, or the first geriatrician in the town or the city that they're going to. That has happened, or sometimes in the country that they're going to. We've had some go back to certain countries and actually start geriatric programs there. The need is huge. In an ideal world, every older person could get a geriatrician, just like most children, have a pediatrician. Because of the shortage, I actually recommend that not happen, and we save the geriatrician services for the oldest and the frailest, or those with dementia. So most of my colleagues, either when if they're in the nursing home, that's usually the very frail elderly. If they're in the hospital, they're doing consultations. We do have a few of our graduates who've gotten to hospitalist careers, but most of them don't. They're doing consultations for the oldest and the sickest. The people who are doing house calls are going out to patients' homes for patients who are homebound. So those are, again, the very frail and the very sick. And those who are in the clinic are mostly functioning not as primary care physicians, but as consultants for those, again, with the geriatric syndromes, the frailty, or with dementia, where their services are really, really needed. Complicated question, complicated answer. I'm so sorry, but we're doing our best. I think JABSM does better than most. I did want to tell you one thing again that JABSM does that's very unique. The JABSM stands for the John A. Burns School of Medicine here at UH. at JABSOM, every graduating medical student in their 4th year needs to do a 4-week rotation in geriatrics and palliative care, regardless of what specialty they're going into. It's a required rotation. Again, given the aging of this country, you would think that was true everywhere. It is not. We're one of a handful of medical schools. I think it's something like less than 10% of medical schools in the United States have a required rotation in geriatrics. So I'm proud that JABSOM is a leader in this field, that even the surgeons, the urologists, the orthopedic surgeons, we are teaching them at least not to do harm to older people when they graduate, and to learn when they need to bring in geriatrics or palliative care services.
Thank you, doctor. I'm sure that you had a lot to do with that, right? You're the one that made that a priority.
Well, it's not just me, Jody. It's really a team of us. My previous boss, Dr. Patricia Blanchette, she was the one who really started geriatrics in Hawaii. So I have to give her a lot of credit for it. I took over for her as chair of the department, but she was the one who was the chair before me. And she's still a mentor of mine. I still call her for advice every now and then, even though she's retired.
Thank you. It is great to send our loved ones to a care home, but for the cost of a care home to be $16,000 monthly is crazy. Everything they saved and worked for all their life is gone in a few months. Do you have any recommendations to protect their assets?
I don't know of any care homes that charge $16,000 a month. That's shocking to me. Usually the care home, the nursing home costs, if they're paid out of pocket, if they're not covered by Medicaid or by other long-term insurance or whatever, it's usually about $10,000 to $12,000 per month. Care homes usually are lower than that. So $16,000 is just shocking to me. In general, though, I would recommend you could talk to a lawyer. They have estate planning lawyers who can talk to you about it, but long-term care insurance is one way, but they often don't cover all of the costs. Unfortunately, long-term care in this country, the majority of it is paid for by patients themselves or by their families. If you can afford it, if you can get into some kind of life care community like Arcadia 15 Craigside, Kahalanui, those are wonderful, and those kind of provide care basically for whatever level of care you need for the rest of your life. But they're expensive to even get into. So yes, long-term care is very expensive and very difficult to finance. And I would say if you do want to think about this, talk to your lawyer early to set up trusts or other things to try and protect assets.
There are two comments about that. Life care in Hilo is $15,000 a month. And someone else said 16,000 is probably an arch. And another person chatted, that's likely for facility care. Our facilities on the Big Island cost 17 to 20K per month, private pay.
That is, okay, so that's even higher than I thought. Wow, that is amazing. I can see somebody running through their savings very quickly at that rate. That's ridiculous. Yeah.
I think we need to stop the questions. We have about 5 or 6 very short ones left, Dr. Masaki.
Okay.
Regarding hospital beds, the beds and mattresses in the hospitals are pretty advanced now. The old school beds, the hand crank ones that are delivered by DME companies to the homes, do not have good mattresses. They're referred to as hospital beds, but are quite different from the ones in the hospital today.
Mm-hmm. I think if somebody is at risk, though, then you definitely should talk to your doctor, whoever's ordering the hospital bed, to talk about what mattress is necessary for that patient.
Thank you. My husband with advanced Parkinson's was on an external condom catheter for 10 years very successfully. Just a comment.
I think you were very lucky. Again, as I said, usually I don't recommend catheters of any type because they can cause a lot of provocation. But I'm so glad that you did not have those problems.
Can the panel or audience list some Oahu senior programs and other senior social clubs that they find to be terrific overall that I can check out? I'm going to ask this person who is anonymous to email me directly, and I'll send you a list.
That sounds great. And the
yeah.
senior handbook is really helpful as well, Jody. Do you all have that access to that?
Yes, that would be on the ADRC. If you Google Hawaii ADRCs, there's going to be a senior handbook for Oahu. You can look at the different county offices and they would have resources for each county.
Those are really helpful. Those senior handbooks are really helpful.
But this person is asking us to recommend the terrific ones. And yeah. I don't think we have time to do that right now, but we can help you via email if you email me. Thank you.
And for dementia specifically, I really strongly recommend the Alzheimer's Association local chapter there. It's called the Aloha chapter. For various different referrals and resources, they are super helpful as well. We do a lot of joint education things together with them. We work with them a lot. I really think they're wonderful people.
Thank you. Very important for families to become the advocate for their loved ones in the hospital and at home. Just a comment.
Yes, I completely agree. You are the best advocate for your loved one. Go to even if it's early dementia, ask to go into the doctor's appointments. Go into the room with them. Don't just wait in the waiting room. Hear what the doctor has to say, because the loved one will not remember. If they have dementia, they will not remember correctly what was said to them. So be there, talk to the doctor, let them know your concerns. I think those are really important factors.
This is another question that can take a long time. What kind of exercises are good for a person with dementia?
Okay, so again, I don't recommend anything complicated. We know that exercise is good for them. For the majority of people, I just recommend walking, simple walking. And our own study here at Kokini in Japanese men has shown that walking alone was good for preventing new dementia, just walking. So I don't necessarily recommend very strenuous exercises. Just simple walking is fine for people. If they've been doing other exercises prior to the onset of dementia, then they can continue that. Again, if they've been completely sedentary, then maybe talk to the primary care doctor before starting an exercise regimen, because you just want to make sure at least there's some safety.
Yes. One person asked, what if a person has a hard time walking?
Yeah, that can be tough. So most older people can at least walk, maybe slowly, but they can walk. For those who maybe they have really bad knee arthritis or something like that, sometimes even walking can be hard. Water exercises can be helpful for those patients. If it's really complicated, if they have a complicated history, then I would say maybe a physical therapist should recommend what type of exercises they should be doing.
Okay, I have a mom with Alzheimer's. She has delirium time. Other than antipsychotics, is there any other medication, specifically something short-term when the delirium happens?
That is such a good question, but also such a difficult question. This is a dilemma that we face constantly. We really try and avoid antipsychotics, actually. That's our last resort medication for patients with dementia. I would say if this is an issue, I can't give you a comment on which medications to try, but I would say this person needs to be seen by either a geriatrician or a neurologist, or even harder to find than geriatrics is geriatric psychiatry, but by one of those types of specialists to address exactly which medications.
Are geriatric specialists involved in teaching the PCP's assessment for dementia? I have found a barrier when a system allows PCP to diagnose dementia, but sends the patient to Oahu level for geriatrician to assess and write lack of capacity letter. This is a difficult barrier from neighbor islands.
Yeah, so no, we do a lot of education for the community, for students of all levels, for medical students, nursing students. We do a lot of interprofessional education among all the schools of UH, and we do a lot of professional education for practicing providers, not just physicians, nurse practitioners, nurses, social workers, etc. So yes, we do a lot of that. The older physicians, when they were training, maybe were not trained in evaluation of dementia. For the younger ones, at least if they've been through JABSOM, hopefully they've at least received some of that training. Many primary care physicians feel comfortable doing the dementia evaluations on their own and then only referring out if it's a more complicated case.
Okay, just comment, mahalo, very practical care tips are useful for home caregivers as well as hospital stays, pressure sores and falls. Thank you. Somebody's asking, have anything on Molokai? This person is a Zoom user, is their identity. And it's really hard for me to respond to people afterwards when you don't put your name. I must say, because of privacy, I understand. But if you want to email me personally, Dr. Masaki, do you want to answer that too about Molokai?
Yeah, I don't know too much about that, but I do know that, Queens, Molokai General Hospital is now part of Queens. And I know the Queens geriatricians at least do some telehealth consults for Molokai, but I don't know too much detail about that.
There are just basic comments here about.
I know there are no geriatricians on either Molokai or Maui or Lanai. And there are a couple of geriatricians on Big Island, but only a couple. One does only, I think two of them actually only do nursing home care, and one does primary care, but is totally swamped. And on Kauai, we have two of our graduates on Kauai, and a third one is going to graduate this June and go to Kauai in July. So Kauai will have three as of next year.
One case manager is saying, heard that if a person does not have a PCP and is to be discharged home, that home care cannot be ordered for them. Is this true, or could the hospital order home care to follow up with the person being discharged?
I think you're right, because you need somebody who's going to be ongoing care of the patient. So if a patient's being discharged from a hospital without a PCP, hopefully the first thing that's going to happen is that they'll schedule a PCP appointment for them. PCPs are hard to find right now. They're really not easy to find. But hopefully somebody will help that person get a PCP, because that's something that I think all older persons need.
Just going to one more comment, and neuropsychologists, specialists can do a full battery of tests that dive deeper than a basic screen and can assist the team. I'm not sure how many are on neighbor islands though.
Yeah, so the full neuropsych testing, I actually reserve that only for people who need it. Most of the time for a diagnosis of dementia, I don't need full neuropsych testing. Just my own history, physical, mental status test is enough to give me that answer. So I only refer out to neuropsychology evaluations, or even neurologists or geriatric psychiatry, only for the very difficult cases where I feel like I need that help. Most of the time, I don't need that. But you're right, that is a wonderful resource to have if needed.
Well, we've gone through all the questions, Dr. Masaki. I think you should have your own radio show or something. Because
Thank you so much.
You're so good at answering questions. Do you see that the results of the poll, all of them are getting it right mostly, but the last question, most older people will not benefit from rehabilitation. There's still about 14% that think it's true.
So let me just comment on that a little bit. Older people will benefit from rehab. The problem is many of them will make very, very slow progress. And unfortunately, the Medicare rules are such that Once they hit a plateau, the physical therapist will often, they'll tell me. So often the family gets mad at the doctor saying, why are you stopping physical therapy? I am not stopping physical therapy. I'm being told that they've met the plateau and physical therapy is going to stop. Sometimes I've actually talked to families to say, if you can afford paying out of pocket for physical therapy, I would really recommend continuing it. And some of them have. Many cannot afford it though. So I really feel it's so unfortunate the way the rules are set up that they will stop physical therapy at a certain point because of that lack of progress. It's just that you have to be patient with older people. Somebody who's 90, their progress is going to be extremely slow, but it may happen. So I like to give people the maximum amount that I can. But again, finances sometimes get in the way of that.
Thank you so much, Dr. Masaki. Before we end today, I just want to encourage everyone to respond to the post poll that we send out when you log off. There's a survey that's going to appear. It's very important for our grant that you answer it, especially the family caregivers. Dr. Masaki, you're brilliant as always. Thank you so much
Jody,
for being here today. And thanks to all 87 people who are still here. And have a wonderful rest of the week. And we'll let you know about our next session coming up on June 15th with Dr. Masaki's associate, Dr. Aida Wen, who's going to present on how to manage dementia behavioral crisis. I'll be sending notice out about that soon. But thanks again, Dr. Masaki. Have a wonderful day. Aloha.
Thank
to
you,
everyone.
Jody, Dorothy, Diane, and thank you all to the audience. Thank you so much. Okay, bye-bye.
Bye-bye.